Assalamu alaikum everyone. Today we will discuss second trimester chromosomal defects. In 1984, Merkatz et al. Reported low maternal serum alpha fetoprotein, which is also known as AFP levels in trisomy 21 pregnancies. Later, studies found altered maternal serum levels of other fetoplacental markers between 15 to 20 weeks of gestation, in which free beta HCG and inhibin A unconjugated estriol, which is also known as UE3, second trimester serum biochemistry. Risk calculation for the trisomy 21 is likelihood ratio of these markers are calculated and adjusted for interrelation between markers and then multiplied by maternal age and gestational age related risk. Risk is increased when HCG or inhibin A levels are high, AFP or estriol levels are low. Screening performance detection rate is 50 to 70%. False positive rate, which is also known as FPR, is up to 5%. And importance of the accurate dating. Pregnancy must be dated accurately by ultrasound. Incorrect dating reduces the detection rate by up to 10%. In first trimester, increased knuckle translucency (NT) is common in chromosomal defect. In second trimester, each chromosomal abnormality show a specific pattern of anomalies. Common chromosomal abnormalities. First one is the trisomy 21, which is also known as Down syndrome, in which brachycephaly, nasal hypoplasia, and rise of knuckle fold, cardiac defects, AV septal defects, and duodenal atresia and echogenic pole, short femur or humerus, central gap, and clinodactyly. In trisomy 18, strawberry shaped head is very common, choroid plexuses, facial anomalies, knuckle edema, cardiac defects, omphalocephaly, limb shortening, overlapping fingers, and rocker bottom feet. And in trisomy 13, holoporencephaly with facial defects, microcephaly, cardiac and renal abnormalities, exomphalos, and postaxial polydactyly. Turner syndrome or lethal type, large cystic hygroma, generalized edema, pleural effusion, ascites, cardiac defects, horseshoe kidney, and triploidy, diandric or molar placenta. Pregnancies rarely last up to 20 weeks, and diagenic thin placenta, severe growth restriction, and ventriculomegaly, cardiac defects, syndactyly, hitchhiker too. This table shows some important major abnormalities where you can see the trisomy 21, 18, and 13, and Turner syndrome, and also triploidy. Ventriculomegaly or skull brain abnormalities. The first one is the ventriculomegaly. Birth incidence is a 1 in 1000 and causes chromosomal defects, genetic disorders, intrauterine hemorrhage, infection, sometimes unknown cause. Sonographic findings, dilated lateral cerebral ventricles. Chromosomal abnormality risk is about up to 10%, and common associations is trisomy 21, 18, 13, and triploidy. Risk is higher in mild moderate cases than in severe cases. Second one is a holoporencephaly. Birth incidence is 1 in 10,000, and it is caused by a failure or incomplete division of the forebrain. And in sonographic finding, we can see single midline ventricle instead of two lateral ventricles. Chromosomal abnormality risk is about 30%. Common associations are related to trisomy 13 and 18 and often linked with the midfacial abnormalities. Higher chromosomal risk when holoparencephaly is other than facial defects. Lower risk when isolated and only facial abnormalities present. Third one is the microcephaly. Birth incidence is 1 in 1000 and causes chromosomal defects, genetic syndrome, hemorrhage, infection, radiations, and in sonographic finding, we can see reduced head circumference. Chromosomal abnormality risk is about 15%. Common associations is trisomy 13. Most fetuses with trisomy 13 do not have microcephaly. If present, often associated with the holoporencephaly.